Hello everyone, this is Rania. I'm a clinical pharmacist specializing in hematology. Welcome to HemaGuide, where we simplify complicated hematology topics for healthcare professionals. In this video, we will discuss the diagnosis and symptoms of aplastic anemia. Aplastic anemia is a disorder where there is a significant reduction in bone marrow blood cell production. This leads to anemia, thrombocytopenia, reticulocytopenia, and monocytopenia. The marrow is hypocellular, but importantly, it does not show abnormal or malignant cells or fibrosis. As we can see here, the difference between the normal marrow and the hypocellular marrow seen in aplastic anemia. There are two main types of aplastic anemia, inherited and acquired. The inherited forms include Fanconi anemia and Shwachman-Diamond syndrome. The acquired aplastic anemia develops later in life due to external factors, and it's the most commonly seen type of aplastic anemia. Now let's look at how doctors classify the severity of aplastic anemia. This table shows three categories: moderately severe, severe, and very severe. For moderately severe cases, hemoglobin is below 100 grams per liter, reticulocytes below 40 billion per liter, neutrophils under 1.5 billion per liter, and platelets under 50 billion per liter. At least two of these criteria must be met at diagnosis, along with a marked decrease in bone marrow cells. In severe cases, the thresholds are lower. Hemoglobin under 90, reticulocytes under 30, neutrophils under 0.5, and platelets under 30. The marrow shows a marked decrease or even absence of hematopoietic cells. At this stage, doctors usually begin searching for a compatible donor for bone marrow transplant if the patient's age allows. Finally, in very severe cases, hemoglobin drops below 80, reticulocytes below 20, neutrophils under 0.2, and platelets under 20. Again, the marrow shows a marked decrease or absence of blood-forming cells, and urgent donor search is recommended. So the lower the blood counts, the more severe the disease, and the more aggressive the treatment approach needs to be, which we will be discussing in the next videos. Aplastic anemia can result from several causes, like autoreactive cytotoxic T lymphocytes, telomere shortening, some drugs, toxic chemicals, viruses, autoimmune diseases, and can be iatrogenic. So, one of the suggested mechanisms of aplastic anemia is autoreactive cytotoxic T lymphocytes, which usually attacks hematopoietic stem cells, leading to apoptosis. Another important mechanism in aplastic anemia is telomere shortening. Telomeres are protective caps at the end of our chromosomes, like the plastic tips on shoelace. Every time a cell divides, these caps get a little shorter. When they become critically short, the cell can no longer divide safely and usually undergoes apoptosis. In aplastic anemia, if DNA repair mechanisms fail, these shortened telomeres lead to premature death of blood-forming stem cells. This reduces the bone marrow ability to produce healthy blood cells, contributing to the disease. Although rare, certain drugs and toxic chemicals can trigger aplastic anemia, especially in individuals with underlying genetic predisposition. And one important example is the combination of cotrimoxazole and methotrexate. This interaction can significantly increase bone marrow suppression, especially during chemotherapy. The UCAL protocol provides guidance on managing this risk. It usually recommends separation of the days on which oral methotrexate and cotrimoxazole doses are given during maintenance courses. Also, it recommends that cotrimoxazole prophylaxis should be paused during periods of high-dose methotrexate treatment. This helps prevent dangerous overlapping toxicities. Once methotrexate therapy is complete and blood counts recover, the cotrimoxazole can be restarted for infection prophylaxis. There are some other drugs linked to aplastic anemia. Anticonvulsants such as carbamazepine, anti-inflammatories like penicillamine, antineoplastics such as methotrexate, diuretics like acetazolamide, and antibiotics such as chloramphenicol. Viral infections can also contribute. Hepatitis viruses have been linked to aplastic anemia in case reports. Epstein-Barr virus may cause aplastic anemia several months after infection, and occasional cases have been reported in patients with HIV. The onset of symptoms is often gradual. Anemia causes pallor, weakness, shortness of breath, and fatigue. Thrombocytopenia leads to bruising, bleeding, and petechiae. Neutropenia increases susceptibility to infections, with fever, chills, and sore throat being common signs of infection. Thank you for watching this introduction to aplastic anemia. We've covered what it is, its causes, and how it presents clinically. But this is just the beginning. In the upcoming videos, we will dive deeper into the diagnosis and the latest treatment options. If you found this helpful, make sure to subscribe and turn on notifications so you don't miss the next part of this series. I look forward to continuing this journey with you. See you in the next video.